It's my pleasure to present our first speaker, and our first talk will be given to us by Assistant Professor Dr. Muhammad Shuraiba, Assistant Professor of Hepatology at the University of Alabama, USA, Birmingham, and a liver transplant specialist.
Good morning, everyone. So it is truly morning time here, and it's not sunrise yet in Birmingham, Alabama. And it's always a pleasure and honor to be here with you. So I am an assistant professor in transplant hepatology at the University of Alabama. And my topic today is about HCC in non-cirrhotic patients. So the state of Alabama lies in the southeast corner of the US, seen here in red on the map. And we pride ourselves for the presence of the University of Alabama here in Birmingham. It was chosen as America's best large employer, something that we're proud of. That's a classification from Fortune magazine. But for us Egyptians in particular, what the UAB is famous for is the presence of Dr. Tinsley Harrison, the author of Harrison's textbook in internal medicine. And he was a native of the state of Alabama, the dean of the school where I'm working at now. And he has a lot of things rightfully named after him, including the Best Teaching Award at the University of Alabama, which I had the honor of receiving that last year. So I have no disclosures related to my talk today. And first, here is some basic information about HCC in patients with cirrhosis. So liver cancer is the 6th most common cancer worldwide, and it represents 90% of primary liver cancers. And it is the 2nd leading cause of death, of cancer-related death. And up to 20% of those HCCs would arise in a non-cirrhotic patient. So here are several risk factors and exposures that could lead to the development of HCC. So most commonly up there on the center, on the top of the screen, is the presence of NASH. So that is becoming the biggest risk factor for developing a cirrhosis and developing cirrhosis in the US in patients below the age of 50, and developing also liver failure needing liver transplant, but also developing an HCC in a non-cirrhotic liver. Viral causes is the hepatitis that we know about, germline mutations, some inherited diseases, and also genotoxic substance that would affect the tumor suppressor genes, including exposure to sex hormones, iron overload, the famous aflatoxin. So we'll dive deep into those causes in our talk. But first, look at that graph there, and it would show you in the dark portion of the column, the portion of HCC that arises on top of cirrhosis. So if you look at NAFLD patients, 65% of those would be cirrhotics, but 34% of those patients will be non-cirrhotic. So that gives you an idea about that 1/3, the big burden of the HCC that would arise from NAFLD. And we do not have guidelines to tell us that we should be doing HCC surveillance on those patients. Maybe we should with the rise in the incidence of NAFLD. Who knows, maybe that will change in the future. So the guidelines are based on the cost effectiveness, and it is felt that NAFLD has still a low incidence overall for causing HCC. Now, we'll look next to that. There is HCV, hepatitis B, alcohol use, and idiopathic causes. Now, our group published on the effect of diabetes on patients that have steatohepatitis, whether it's related to alcohol or related to NAFLD, and we found that the presence of diabetes on its own is a risk factor for development of HCC, as you can see there on the graph. So how does that work? Well, first, it is the most common cause, so you expect to see a lot of non-cirrhotic HCC related to NAFLD. And diabetes and obesity act basically as an inflammatory status that releases cytokines, paving the way to the development of HCC. Common ones would be TNF-alpha, IL-6, and leptin. So metabolic syndrome also, if it's found in other causes of chronic liver disease, including hepatitis B and hepatitis C, it can increase the risk of developing HCC. HCV is another cause. So hepatitis C virus is not really as oncogenic as hepatitis B virus, but yet it can contribute to the risk of developing HCC. The risk is felt to be less than 1% per year, and hence the lack of guidelines regarding surveillance for HCC in those patients with chronic hep C that do not have cirrhosis. So the risk factors would include male gender, age, elevated liver enzymes, the presence of steatosis. Again, you can see here how NAFLD would overlap with any other condition and increase the risk of developing HCC in a non-cirrhotic. Diabetes and alcohol use as well. Hepatitis B virus is quite oncogenic compared to hepatitis C. And there are certain high-risk population that you should be surveillancing for HCC development, irrespective of the presence of cirrhosis. So this is probably the one and only area where we have the recommendations from the ASLD and other societies regarding HCC surveillance. So those are Asian men above the age of 40, Asian females above the age of 50, patients, Black patients, and patients that have family history of HCC. Now, when it comes to patients that have chronic hepatitis B and do not meet either one of those four categories criteria, you can expect also that they would have a risk of developing HCC. So this is a personal practice away from the guidelines. I tend to screen those patients for HCC also. Now, the next thing is hepatic adenoma. It has a risk of about 5% to develop HCC per year. And that risk increases with increase in the size greater than 5 centimeter. Patients that have on imaging telangiectatic changes, male patients are more likely to develop HCC than female patients. And then the development of the beta-catenin mutation. So if we find that on a biopsy that we did of an adenoma, then we lean towards resection of that adenoma. Sex hormones exposure would also increase the risk of developing HCC. So if you look at androgen use in bodybuilders, they do have a risk of developing HCC in a non-cirrhotic liver. And there are two proposed pathways for that, either through development of adenoma that evolves into a carcinoma down the road, or de novo development of carcinoma. And oral contraceptives are associated with a 4.4-fold increase in the risk of HCC in some studies. The fibrolateral carcinoma, or the fibrolateral HCC, is a very interesting one. It arises typically as a catastrophe in a young patient. In the past, it was felt to be more in female patients, but more recent study shows that it can affect male patients as well. And it is more common in Caucasians, and it contributes to about 5% of all HCCs that we see here. Surgical resection is typically the treatment there, but it's a notorious tumor known for metastasis and high rate of recurrence of more than 50%. And as you can see in the histopathology there, characteristically, the hepatocytes would line up in layers, and also you see bands of fibrous tissue, and typically large tumor on imaging. So hence the name, the fibrolamellar. Next, alcohol exposure. So it can contribute to oxidative stress in the body, production of endotoxins and inflammatory cascades. However, it may not be that much of a risk in the absence of cirrhosis. But if the patient develops an HCC and they continue to use alcohol, they do have a rapid progression of HCC. And we do see that quite a bit in our practice here. Now, iron overload and other toxins exposure are also causes for development of HCC in a non-cirrhotic liver. And there are several proposed mechanisms for that, but probably the most important one is the mutation of the tumor suppressor genes and oxidative stressors that lead to the development of HCC. Other chemicals include vinyl chloride, methylene chloride, and nitrosamines. Inherited diseases include hemochromatosis, alpha-1 antitrypsin, acute porphyrias, Wilson disease, glycogen storage disease, and Alagille syndrome, which is characterized by the low-lying ears and the butterfly spine, and cholestatic picture usually on presentation. So those are some of the inherited diseases that could lead to HCC in a non-cirrhotic liver. Now, next, an interesting one, which is the aflatoxins. So it is produced by two Aspergillus strains, the flavus and the parasiticus, and typically in grains that are stored in hot, humid conditions. So this can be seen in sub-Saharan Africa, Southeast Asia, and China. So any grains that are basically kept in hot and humid weather could allow for the growth of that type of fungus and the production of aflatoxins. And it does lead to mutation of the tumor suppressor gene, the P53, and patients that have chronic hepatitis B are at a higher risk of developing aflatoxin-mediated HCC. So how do we diagnose an HCC in a non-cirrhotic liver? We go through the traditional path there, but keep in mind that the clinical picture is deceiving. Most of those patients will be asymptomatic. They don't have manifestations of cirrhosis or decompensation that will get your attention there. And if you're talking about a limited sensitivity for alpha-fetoprotein, that could be as low as 60% in a cirrhotic, so meaning the AFP can miss 4 out of 10 HCCs. It is even lower in patients that are non-cirrhotic. It could be down to 31%. And then it is normal in patients that have the fibrolamellar type that we talked about. On an ultrasound, the lesion could be hypoechoic, like you see on the top image there, or it could be hyperechoic. And as we all know, the ultrasound is quite disappointing in terms of early detection of HCC. Now, CT or MRI will probably have more sensitivity there, and that might sound redundant to the expert crowd there, but you really have to have the CT or the MRI done as a dynamic, multiphasic, or 3 or 4 phase study, because otherwise, if it's done the traditional way, non-contrast followed by contrast, that may very well miss the presence of an HCC. MRI is more sensitive, and it can show you the fat that sometimes you see in fat-containing HCC. Liver biopsy has a sensitivity of 60% to 93% based on the tumor size, and it can be done in an inconclusive imaging of the patient, or to establish the diagnosis for the purposes of planning systemic therapy or liver transplant. But resection remains really the best treatment and probably diagnostic modality there. And we refer to it sometimes in our tumor board meetings as the big biopsy. A negative liver biopsy does not exclude HCC. Now, how's the treatment done? We just mentioned that surgical resection is the cornerstone of the treatment. It has excellent survival rates, so 96% in the first year. But look at the next line there. The disease-free survival rates are low, meaning that you expect that half of your patients would develop at year 5 recurrence. But remember, we said that those patients have intact synthetic functions. They have a non-cirrhotic liver, so they can always go for a repeat hepatectomy if feasible. Liver transplant is considered in non-resectable tumors or intrahepatic recurrence after resection. So we cannot get those non-cirrhotics listed. We cannot get them exception points for liver transplant. But if they do have recurrence or they are non-resectable, then we can look at the possibility of listing them. Of course, they need to have no macrovascular invasion or extrahepatic spread of the HCC. Systemic therapy with sorafenib and other agents, including mTOR inhibitors, we've tried that mainly for prevention purposes after liver transplant. Not much data in the field of HCC in non-cirrhotic. RFA and TACE are widely utilized, radiofrequency ablation and trans-arterial chemoembolization, widely utilized in HCC in cirrhotics. But I'm not sure that they have the same utility there unless your patient is not a resection candidate. What we're utilizing heavily those days is the use of yttrium 90 or the Y90, and we find that helpful in particular in that situation here shown on those multiple images. So this is a patient who had a very large lesion and was not a candidate for resection. And basically the patient went for Y90 followed by portal vein embolization just to allow that left lobe to get bigger and hypertrophy. And then at the very bottom in image H there, you see that the patient had resection and the left lobe is showing quite a bit of hypertrophy. So in summary, HCC in a non-cirrhotic patient represents about 20% of the HCCs that we will see. And it is usually presenting in advanced stages, and there are no formal recommendations as to how to surveillance those patients. We all abide by the multidisciplinary approach as per the ASLD guidelines, meaning you really need a room that has a hepatologist, oncologist, IR person, of course, a surgeon, and that usually gives you the best outcome. Surgical resection is the mainstay of the treatment. It offers excellent survival rates. Yes, there is high recurrence, but you can always resect those patients again. And liver transplant can be selected in certain cases as a treatment option, as we discussed. Those are some of my references, and I would like to end by saying thank you to everybody here. And it's always a pleasure and an honor to be with you. Thank you so much.
Professor Shuraiba, thank you so much. With you, Mona Higazi. I'm really honored to be with you again. When I suggested this topic on Hadi, I know that they are the best one can tell us more about the hepatocellular carcinoma on non-cirrhotic liver. Thank you so much. And I want to emphasize that the absence of a surveillance in the fatty liver for hepatocellular carcinoma leading to missing a lot. We need a surveillance program for fatty liver for hepatocellular carcinoma, and especially because the rare one, especially it's almost 10% the fibrolamellar type, but can occurring in young age and presenting when it's already making extrahepatic metastasis. And this is the problem of the fibrolamellar type. Thank you again. We emphasized that we must need a surveillance program for fatty liver searching for hepatocellular carcinoma, even from 18 years and to 20 years, young population with the higher incidence of the fatty liver disease and fibrosis we had in Egypt. Thank you so much for the illustrative, highly structured and scientific lecture. Thank you, sir.
Thank you very much. Well said, Dr. Mona, and it's always a pleasure and a privilege.
Thank you.
Thank you, Professor Mohammed Shuraiba, for this very interesting and elegant presentation. And now speaking of surveillance programs, our next presentation will be presented by Dr. Mohammed Abdullah, lecturer of endemic medicine at the National Research Center and the medical coordinator of the National Committee for Control of Viral Hepatitis. And he will give us a short talk about surveillance programs for hepatocellular carcinoma.
Bismillah ar-Rahman ar-Rahim. First of all, I'd like to express my thanks to Professor Sarek Zakaria and dear chairpersons, dear attendants. Thank you for your listening. Our talk today will be about HCC surveillance, and we'll make some focus on the Egyptian situation in our lecture. First of all, hepatocellular carcinoma is a major healthcare problem. According to GloboCan 2020, liver carcinoma is the sixth most common malignancy in number of new cases, and the third most common cause of cancer-related deaths globally. In Egypt, and according to National Cancer Registry, liver cancer is the most reported malignancy, with about 23.8% of cases. The prevalence in males are a little bit larger than females, 33 versus 13%. According to GloboCan 2020, also liver cancer is recorded the highest malignancy in number of deaths, about 29.8%, and in incidence about 20.7%. There are many risk factors, as mentioned by Dr. Mohammed in the previous lecture, and of course, in our region, HCV is recorded the highest cause of malignancy. It's about 44%. The annual risk of developing HCC in HCV-related cirrhotic patients is about 2 to 8%. And when HCC occurs, the rate of cumulative recurrence is known to be 70% over 5 years. Therefore, a global action plan needs to be taken. And in 2016, WHO has launched the global strategy targeting viral elimination by 2030. This program was not only by aim to deliver medications to treat HCV and HPV, but also it stated that in addition to antiviral treatment, chronic care is required, including management of decompensated liver disease and the hepatocellular carcinoma. Therefore, Egypt has launched since 2006 an ambitious program through the National Committee for Control of Viral Hepatitis in 2006, with many successful steps, such as introduction of DAs at 2014, introduction of generic medication in 2016, and reaching the achievement of presidential initiative campaign at 2018. This campaign was able to screen more than 48 million Egyptian citizens, and it reported that there is HCV prevalence declining from DHS 2008 15% to 5% in 2018. But would that make a change in the magnitude of HCC dilemma in Egypt? A study was predicting the numbers of HCC patients recorded that if this study was at 2015, and it said that if we were able to treat 1 million cases in the next 4 years with a decrease of incidence between 2016 and 2020, it will be the best scenario for the future estimates for HCC. And I think we are on this track, inshallah. But this massive treatment raised the issue of the dilemma of HCC and direct-acting antivirals. Is there a relation between both of them? And according to a many Egyptian review, it stated that there is a conflicting results regarding the risk of developing HCC after DA exposure, and it may be due to geographical and ethnic variations and differences in design and inclusion criteria among the studies. And as we can see, there is a huge discrepancy between the results of all studies included in this review. Additionally, another study, Egyptian study, reported that there is a successful management of HCV in previously treated HCC, but there is a high rate of recurrence was observed, especially in the first 6 months of treatment initiation. And therefore, it's recommended that surveillance in cirrhotics should be continued even after achieving SVR. Now we are shifting to the surveillance in between EASL guidelines and ASLD guidelines, being the most widespread guidelines on the world. Are they agreed on the points of surveillance, or there is a difference between both of them? The first question, who should be screened? According to EASL guidelines, screening is usually done or recommended to all cirrhotic patients, child A and B, and the cirrhotic patients, child C, if they're only on liver transplantation lists. There is another recommendation, as Professor Muhammad said in previous lectures, for non-cirrhotic HPV patients and non-cirrhotic F3 patients based on individual risk assessment. And the rule of surveillance for patients of NAFLD without cirrhosis wasn't unclear. But on the other hand, the ASLD guidelines agreed on the main terms like EASL. It recommends surveillance to all cirrhotic patients except child C, unless he is on transplantation list, given the low anticipated survival for patients with child C cirrhosis. And the risk of HCC is significantly lower in patients with NAFLD without cirrhosis, and it's also agreed that surveillance is not recommended for these patients. What is the preferred screening interval? According to EASL, interval should be dictated by rate of tumor growth and the incidence in target population. And stated that 6 months is a good and reasonable and cost-effective period. And stated that if we do a 3-month interval surveillance, it will be has no clinical benefit. And 12-month surveillance may be lead to fewer early-stage diagnosis and shorter survivals. Additionally, ASLD agreed on the same term, and it recommends every 6 months surveillance. But it stated that modification in surveillance strategy based on etiology and liver disease or risk stratification model cannot be recommended at the time. This is another study that compares the time interval according to different guidelines, and most of them agreed on 6 months interval for screening. So, what's the preferred screening tool? According to EASL guidelines, it preferred to use ultrasound is the main method of choice. The serological tests are not currently cost-effective according to EASL guidelines. Tumor biomarkers for accurately early detection are still lacking. On the other hand, ASLD added alpha-fetoprotein for the recommendation and surveillance, and stated that alpha-fetoprotein is expected to increase the sensitivity of surveillance ultrasound. And despite of the high performance of dynamic imaging, CT or MRI, but it's not cost effective to use them in surveillance. According to novel biomarkers for surveillance, alpha-fetoprotein L3 and DCB are both a new novel biomarkers for use approved by FDA for risk stratification. But it's not until now approved for using for surveillance. There's a diagnostic model called GALAD, which incorporates alpha-fetoprotein L3, DCP, according with patient age and sex, does a promising results in phase 2 studies, but larger studies needs to be done to approve it for usage. There is no much difference between EASL and guidelines in the diagnostic algorithm for surveillance. The main issue was that we need to focus that if there is a suspected lesion less than 1 centimeter, according to EASL, it's recommended to repeat it at 4 months. If it's stable, we will still on the surveillance. If there is a changing pattern, we will move to further steps. ASLD agreed with that also, and it recommends repeating ultrasound in every 3 to 6 months instead of 4 in EASL guidelines. So what's about cost effectiveness of surveillance program? Both guidelines had agreed that the decision to enter patient in surveillance program is determined by the level of risk for HCC, while also taking in account the patient age, overall health, functional status, and the willingness to apply and comply with surveillance requirements. The level of HCC risk, in turn, is indicated by the estimated incidence for HCC. Cost-effectiveness studies indicated that incidence of 1.5 per year or greater would warrant a surveillance in cirrhotic patients is effective irrespective of its etiology. But in patients with HPV, the incidence it will be 0.2 per year. In general, an intervention is considered effective if it provides an increase in the longevity of around 100 days. Interventions can be achieved at a cost of less than approximately $50,000 per year of life gained is considered a cost effective. And the several published decision analysis cost effective results has approved that surveillance is generally a cost effective. And therefore, EASL guidelines has encouraged implementation of screening programs to identify at-risk candidate populations. And such programs is a public health goal, aiming to decrease HCC-related and overall liver-related disease. And therefore, Egypt has, after the surveillance, success in the HCV treatment program started in 2019, we started a national surveillance program for hepatocellular carcinoma in patients with liver cirrhosis. The patient was offered a free visit every 4 months where abdominal ultrasound and alpha-fetoprotein tests are used to screen for HCC. This program is not dedicated only for HCV patients, but it expanded to cover all the causes of cirrhosis. Suspected cases are electronically referred to specialized centers for dynamic imaging or to multidisciplinary teams for the management. I hope this program will succeed as the HCV program, and for sure, all patients with liver cirrhosis and patients with non-alcoholic fatty liver disease, as Professor Mona said, needs to be done, has to be surveilled under surveillance program. And thank you.
Thank you so much, Dr. Muhammad Abdullah, for this lovely presentation and a very important step and initiative indeed. Our next presentation, we will have a very interesting debate on the role of immunotherapy in the management of hepatocellular carcinoma, and this debate will be presented to us by Professor Muhammad Abdullah, Professor of Clinical Oncology at Cairo University, and Dr. Ahmed Magdi, Lecturer of Clinical Oncology and Hematology at the National Cancer Institute and the Medical Director at Shifa Al Orman Hospital.
Thank you, dear Hedy, for your introduction.
questions في الاخر ولا احنا عايزين interesting session فعايزين نسال حاجات
اللي حضرتك عايزاه
زي ما حضراتكم تحبوا
تحت يعني تحت امرك. شكرا جزيلا. Thank you, Dr. Hedy, for your kind introduction to me, and I admire the kind invitation of the organizing committee for me for this presentation. Actually, as we know that HCC, as management of HCC, as we are looking through a blackout view, it's a heavy burden on health resources, and the problem now in Egypt, it's endemic disease. Here by my disclosures, and as you see, we are one of the most hottest areas around the world regarding the incidence and the mortality rate. This publication in 2014 addressing the real incidence of malignant diseases data came from 5 major cancer centers across the country. That liver is the first disease to be encountered among males, second among females, and when we consider the entire population, males and the females, it's number 1. This is an expectation from the disease prevalence and the growth of the population that by the year 2050, we do expect it to have more than 85,000 cases per year. This is coming to be somewhat near the real life situation, but this is only coming from 5 cancer centers. Still, due to the variety of our health resource systems, so the real incidence is not really, or the real numbers are not really appreciated. This is regarding the global survival outcome. We have different variations coming from the Far East to the Western world to our region. Definitely in the Far East, this is the best survival anticipated in Taiwan and Japan, more than 5 years. More than 5 years. While in the Western countries, the median survival for HCC cases around 20 to 30 months. In Egypt, it's about 11 months, and in other African countries, about 3. To characterize the disease landscape in Egypt, this publication in the Lancet Gastroenterology and Hepatology, published in 2017, for what we have about the liver cancer in Africa in general. Actually, half of the cases were presenting from 2 centers in Egypt, while the remaining 50% from the other African countries. And this is a characterization that definitely HCV accounts for more than 80% of patients with HCC. Most of cases presenting with multinodular disease, macrovascular invasion, and the minority with extrahepatic metastases. Actually, the performance of the patients were quite good in the majority. ECOG performance status 1 and 2, and this is quite misleading. When we go for the child scoring, it's more than 60% as B stage, and according to the Barcelona clinic liver cancer, it's C stage in about 60%. Mostly our patients are going to be offered the treatments. They will not be left for best supportive care. We have a variety of applications regarding the interventional radiology, the systemic diseases, and even for surgical resection in the minority of patients. This is the survival anticipated. And for the prognostic factors encountered with the bad outcome, that to have a patient with hepatic encephalopathy, high level of alpha-fetoprotein at presentation, large tumor sizes, and poor performance status. Moving a step forward to the molecular backstage of the disease, responsible for the disease aggressiveness and resistance to the treatment, we have many of the biological cascades initiated through stimulation of certain receptors present on the cell membrane. Then upstreaming of this biological input will lead to evoking the malignant disease, the angiogenesis, proliferation, invasion, and hence metastasis. And we have a lot of agents tackling such receptors, whether to tackle the extracellular domain of the receptor like the monoclonal antibodies or tyrosine kinase inhibitors. And as angiogenesis is a hallmark of malignancy, all of them are going to tackle such a phenomena either through the receptor itself, through the anti-angiogenic agents like bevacizumab, Avastin, and we have a long-standing experience now with this drug, more than 20 years now. And for the intracellular domains, the tyrosine kinase inhibitors, one of them is sorafenib, and I think this was established as a line of the treatment for the advanced and the metastatic disease in Egypt since 2007. However, I will tell you some secret. Although I was one of the steering committee introducing sorafenib to Egypt by the year 2007, and Professor Srag also, and my dear late Professor Sameh Labib, Dr. Zayadi, all the famous names in the field of the hepatology and the gastroenterology, I didn't prescribe the drug for any patient with HCC except 2 to 3 patients over the last 15 years. Okay, sorry to tell so. I wrote it for patients with other indications like the medullary thyroid cancer and some other indications, and it was successful in this. But for the liver cancer, believe me, I wasn't impressed. I don't feel I am honest and ethical if I'm going to offer it to a patient with HCC, and I have my own reasons for this. This is the timeline of the FDA approvals for the HCC, as you see, since 2007. Before this, actually, we had nothing. But then, till the year 2020, this flood of agents, the pharma industry and a lot of things we're sharing for the therapeutic platform more and more. And as you know, now every family, mostly you will have a cirrhotic patient, and mostly you are going to face HSCC at its end stage of disease. At this point, it's a critical question to treat or not to treat. This is really, I'm sure that you are all astonished as an oncologist, how come I'm not with giving such sticky eyes or such a dilemma to all my patients. The problem is, when I see a patient with HSCC advanced, usually his symptoms are not due to the disease. It's due to the advanced cirrhotic state. So the patient is going to ask me a simple and straight question. Would I be okay after receiving the treatment? Can I go again to pray in the mosque? Can I go to deal with my own issues? Definitely. The answer, if I'm honest, it will be no. I am tackling other issue, which is the malignant disease, which is not leading to any of your symptoms unless metastatic. Here we can do something for the patient, not from the drug therapy, but from the other palliative maneuvers. Forgive me for telling you so, because really, management of HSCC in Egypt is hurting me a lot. All the team members are hurting me a lot. I'm not a robot, I'm not an angel. But when we think what we are going to add to the misery of the patient, even if clearly indicated to receive the treatment in the right way, by trials, by guidelines, by everything. Today, you are seeing the patient while he's walking and coming to your clinic. Next week or next month, believe me, instead of being in child A level, he's going to deteriorate immediately to child C. And if he's coming to you alone, the next time he's going to come with you, accompanied by some of his families to help him. This is a real black view of what we have. So I think we need to understand more and more the backstage of the disease. So far that when we are going to treat, we will help the patient and fulfilling his demands. Definitely the survival is important, but to fulfill the patient demands, this is upfront priority for every practicing physician. Sorry for this, it's out of the scope of the presentation, but it's my message, always delivering this, and I know that I have a lot of enemies because of this. Forgive me for this. Anyway, let's go to see what sorafenib had added for patients, and this publication is about 2 years ago for analysis of the phase 3 recognized sorafenib against variety of comparators, the placebo, some against active treatments, and at the end of the day, the patients were, the minority of the patients actually, were considered HCV positive. Remember this point. Although they have a perfect child score classification. When we go to the survival outcome, not more than 10 to 11 months is on the best hand, while the progression-free survival were about best to be 5.5 to 6 months. And they considered among the worst prognostic factors to be associated with the sorafenib use is to have HCV positive, those with macrovascular invasion, extrahepatic disease. Definitely, any of them would be a bad prognostic factor to use of the sorafenib, and they concluded statement very important that in the absence of macrovascular invasion and extrahepatic disease and the HCV etiology associated with higher likelihood of survival. If we don't have the three, we will have good survival. And for patients with HCV or viral hepatitis, and other than HCV, we have the B also virus, you can go to the second treatment line, which would be the immunotherapy, because now we are living in the immune era. And we will see why we should not think simply of this as the safe guide to our patients. This is the results for all other anti-angiogenic TKIs. The survival wouldn't improve above 10 months. And the same for the progression-free survival. But what was really of interest is the disease control rate. Disease control rate, it's a new terminology considering those with complete responses, partial responses, and the stable disease. They consider the addition of stable disease as a good sign for the patient. And I think this is okay, because at this point, if you are going to lose your control of the disease and it will progress, this means that you are going to lose your patients. So the final statement that the median overall survival is about 10 months, median progression-free 3 to 5 months, overall response rate not really impressive, about 20%. Why I'm focusing on the overall response rate? Because it might be associated with alleviation of the symptoms. And the disease control rate, you are going to keep your patient alive, so far is not progressing, in about 50%. Now, back, and always old is gold in music, in life, and in everything. Since 411 before Christ, where Thucydides, which he was a Greek scientist, noticed that recovered people from plague can serve patients without catching the disease again. Many hundred years later, where Edward Jenner developed the first modern vaccine in 1790 against the smallpox, to the modern and real situation of the recent vaccines imposed by Louis Pasteur, where he stated the basic and scientific concept for vaccination, and that we have a natural bodyguard inside our bodies. Once it will detect a pathogen, it will mount an immune response to help you to beat against such invader. William Culey, American orthopedician, in the early of the 20th century, following injection of a recipients killed bacteria into a sarcoma lesion, followed by tumor shrinkage. All of them are pointing to the role of immune system, not only against live organisms like bacteria and virus and so on, no, but also against the invaders coming from inside our bodies, the malignant diseases. Here are our cellular key player, our soldiers. Of them, we have the stimulants for the immune system, but also we have some brakes that will hinder your immune activation, immune system activation, to prevent tackling your own natural body systems, to keep your body systems away from destruction by your immune system. This is simply what we have as an immune scenario to tackle cancer. It started with the release of the tumor antigens. They are proteins, peptides, released as a result of the death of the cell kill that's going to be taken by the cancer antigen presenting cells, the dendritic cells, that's going to act to stimulate the T cells by their all types, where they are also under another accelerators and the brakes, co-stimulatory points and the co-inhibitory factors. Then the activated T cell will traffic to the tumor to infiltrate it, to recognize the cell, and then it will lead to kill of the cancer cell. However, this is not the almost always scenario. Still, we will have evasion of the immune system. The tumor will be capable of evading the immune system. Among the co-inhibitory points responsible for softening of the immune response, we have the program death ligand 1 and program death 1 and cytotoxic T lymphocytes associated 4, CTLA4. So if you are going to inhibit the brakes, you are going to remove the brakes, you can expect that you will have acceleration of your car. So you will enhance the cellular killing. This is the basic for the immune therapy mechanism of action against the malignant disease. Now, back to our Jean Bromère, to our HCC, our star today, our guest of honor, that the etiology, you know the etiology better than me, definitely the viral and the metabolic. But what I wanted to show or to remind you that in the viral etiology, upon exposure to the HCV, HBV, or maybe others, will initiate a state of chronic inflammation, where we will have something called the necroinflammation. This will add to the development of HCC directly. While for the other metabolic syndromes, what we have here, we started to have the real deregulation of the immune system. We will have imbalance between the stimulators and the inhibitors. So it could be part that can be tackled by the immune therapy. Necroinflammation, the products of death of the cells, are going to express a lot of the anti-inflammatory cytokines. They will lead to suppression of the effective anti-tumor immune response. Take care of this. This is very important. Also, among patients with HCC on top of HCV, the immune cells, we have depletion of the active immune cells. As we are considering this an immune tolerant organ, there will be exhaustion of the effective T cells. And when we try to stratify the cellular, the immune cellular infiltration within the tumor microenvironment, you will focus that the CD8 T cells, they are one of the active cells. It might be increased or decreased, while the natural killer cells, natural T cell, are going to be definitely decreased. This is simply what we have as an immune infiltrate. In red squares, you can notice this only the cells associated with anti-tumor effect, while the other list, the whole list, will promote the tumor growth. Again, don't forget that we are talking about an immune tolerant disease, which is really an important situation, because long-standing cirrhosis with the development of the HCC, there will be a lot of the release of the tumor-associated antigens like the alpha-fetoprotein and the others, so they could be a target for the dendritic cell vaccination. However, due to the continuous crosstalk between the alpha-fetoprotein and the target, the CD8 T cells, there will be decrease of the cytolytic activity of the T cells, of the cytotoxic T cells. However, it will be regained against other viruses like the CMV and Epstein-Barr virus. So the problem is related not to the continuous viral infection, but to the continuous exposure by the HCV itself. There is something that we do not know yet now. Here is for the PD-L1 as expressed by the tumor cells and responsible for softening of the immune response. It's not that expressed really much in the HCC. This is the immunologic classification of the HCC, where they consider that the immune class would be possible only for 30% of cases. So finally, this is what we have as challenges for the HCV-associated HCC regarding the role of necroinflammation, the immune-tolerant organ, the presence of T-cell exhaustion, decreased activity of the natural killer cells and the other cytotoxic cells, the immunosuppressive microenvironment, and others. So immune checkpoint inhibitors, which are really in use now, in a lot of use against cancer as an immunotherapy would not be suitable as a monotherapy for patients with HCC. Just before I leave, I do think a lot about the IO monotherapy among patients with HCC. Maybe I am thinking about IO combinations, and my friend and the colleague, Dr. Ahmed, is going to see you how we could improve. And finally, we have weapons without an army. Thank you very much for your attention. Sorry to exceed my time. And I let the floor for Dr. Ahmed Magdi.
So first of all, thank you for inviting me to be among all the eminent hepatology professors. It is an honor, and specifically to talk in front of my godfather, Professor Ahmed Sami, and my mentor, Professor Muhammad Abdullah. So I'll try to convince you in a very short time, did we do something with the immunotherapy? Are we there yet? Can we do something with the HCC? Let's see. Sorry, these are my disclosures, and I'll just bypass these because it has been mentioned before. So we'll start with the hepatocellular carcinoma microenvironment. So why are we tackling hepatocellular carcinoma for immunotherapy? Is there a role, or is there a reason behind that? Actually, quoting Professor Muhammad Abdullah, the liver is actually a highly antigenic organ. So it's continuously exposed to antigen from the gastrointestinal tract. So this makes the organ full of immune cells, and it's really immune active. But this immunoactivity will actually lead to immune tolerance. What do I mean by immune tolerance? Is that the liver is full of antibodies and then it starts fading out. Why? Because it's continuous exposure to antigen. It's the first pass effect from anything entering our body. So there is an immune tolerance. And what do I mean by immune tolerance? From all these cartoons, you will find that the red lines are the suppressive lines for hepatocellular carcinoma. So what do we mean? If I do have, so just to mention quickly, it overexpresses, for example, the programmed death ligand 1, PDL1. The overexpression of PDL1 will lead to suppression. Oh, let's see, this is way better. So the PDL1 and the PD1 overexpressed will lead to suppression of our major killer cells, the CD8 cytotoxic T lymphocytes. And then also by overexpression of the CTLA4, we will depress or suppress CD4 helper cells. So basically hepatocellular carcinoma, what it does is puts our immune system to sleep and hides from our immune system. Okay, and with the liver cirrhosis, and the Kupffer cells acting here, again, and the hepatocytes, actually they lead to more suppression with not only with PDL1 and CTLA4, but with LAG3 and FOXP3, which are the new players. So why are we talking about immunotherapy now? Immunotherapy is the new era in the treatment of cancer. So it started in 2011 with melanoma, and 2015 with lung cancer. Now it's indicated in more than 30 types of cancers, up to the FDA has sent a broadcast that if you find any tumor with overexpression of PDL1 more than 50%, you can use immune checkpoint inhibitors even if there are no clinical trials. Why? Because they are gaining ground very fast. So why immunotherapy in HCC? Again, HCC is a classic inflammation-induced tumor. You've all mentioned, all the professors before me mentioned that inflammation by hepatitis C virus and less common the B virus. Yes, we do have. And then it gets in spontaneous immune responses independent of liver functions, and it could be, you can combine with ablative therapy. So when you do an ablative therapy, you induce inflammation, bringing more immune cells in the field. Does this translate it that I can use my immune checkpoint inhibitors? Let's see. So rationale was, again, as I showed you, that survival in hepatocellular carcinoma was found to be less with the low PD-L1 with the overexpression of PD-L1. So whenever the hepatocellular carcinoma expresses PD-L1 high, then the hepatocellular carcinoma survival is low. Then I just mentioned a few slides ago that if I use immune checkpoint inhibitors with PD-L1 high, I should get an overall survival, right? Let's see. So what about immunotherapy as first line? Professor Muhammad Abdullah showed us that the sorafenib is already gaining ground, and it was till 2 years ago, it was the first line approved in the guidelines, okay? Why? Because it has a vascular endothelial growth factor effect, inhibiting the VEGF. So coming back to what Professor Muhammad Abdullah ended his talk, monotherapy is not recommended because hepatocellular carcinoma has high expression of VEGF, so I need to tackle the VEGF plus the immune checkpoint inhibitors. So sorafenib naive patients were offered nivolumab, which is an anti-PD-L1 inhibitor, in 2 doses. Overall safety and survival, the median overall survival was 28.6 months. Wow, this is really impressive. But this was not a standard or a randomized phase 3 clinical trial, so this was not a high level of evidence. Then we got to Checkmate 459, which is a phase 3 clinical trial comparing nivolumab with the standard of care at that time, which was the sorafenib. And then it was prescribed until unacceptable toxicity or disease progression. Just to put on your minds that immune checkpoint inhibitor has a major toxicity profile that we cannot tackle, which is money. So it's a very, very, very expensive drug to use. So nivolumab or immune checkpoint inhibitors in general costs per month from 60 to 80,000 per month for a terminal HCC case, and I'll show you if we do have response or not. So as you can see here, the overall response rate or the overall survival with the nivolumab 16.4 versus 14.7 months, with only a hazard ratio of 0.85, and actually it wasn't statistically significant. But if you look at the force plot curve or the force plot diagram, you will find that most of the subcategories or subgroups were in favor of the nivolumab. Then if we divide the patients according to the PD-L1 expression, so less than 1% is negative PD-L1 expression, over 1% is PD-L1 expressed. But then we do have categories of 1%, 25%, and then 50%. And this shows you that we do have a strong weapon that we don't know how to use. Because up till now, there is no unification to measure the PD-L1 expression. So if you're using one drug, you're going to use a specific test. If you're using another drug, you're going to use another test, okay? So if we look at the patients with more than 1% expression, then you'll find that there is a better survival of 16 months versus 8.6 months for sorafenib with a hazard ratio of only 0.8. So meaning that I only have 20% of my patients will respond to single agent nivolumab. However, in less than 1%, there is actually definitely no difference between nivolumab and sorafenib with a 16.7 months versus 15.2 months. So basically it's nothing. What about progression-free survival? As you can see, both actually has the same progression-free survival. So I'm showing you that immune checkpoint inhibitor as a single agent versus the standard of care sorafenib doesn't add much. And if you look at the guidelines, nivolumab didn't even jump to first line yet. What about another immune checkpoint inhibitor, which is one of the oldest, which is the pembrolizumab, and adding to it another drug, which is the lenvatinib or the Lenvima, which is a new player or a newcomer in HCC. By the way, if you compared it to sorafenib, both of them had the same outcome, however, a little bit lesser toxicity. However, according to recommendation, I would ask my professor here, are you writing lenvatinib, sir, in hepatocellular carcinoma? Yes. But again, sorafenib, no. So this is an ongoing trial, actually, and it's not yet published, or I mean reported. Another ongoing phase 3 trial, which is a durvalumab, which is an anti-PD-1 and not PD-L1. So L is the ligand, PD-1 is the protein that binds to the ligand, the receptor. Again, another immune checkpoint inhibitors with a combination with something called the tremelimumab, which is an anti-CTLA-4. So combining two immune checkpoint inhibitors. Again, financial toxicity, a lot of side effects. So what if we combine them? So I showed you that immune checkpoint inhibitors do act a little bit, right? Can we combine and add? So we showed you that VEGF is highly expressed in hepatocellular carcinoma. So why don't we combine immune checkpoint inhibitors with anti-vascular endothelial growth factor? For example, here is the bevacizumab, which is known in the market as Avastin and now has lots of biosimilar, versus atezolizumab, which is immune checkpoint inhibitor as single agent. The overall response rate, as you can see here, is 37%. And if you look at the progression-free survival, yes, you'll find a benefit for progression-free survival with an excellent hazard ratio of 0.55. So 45% of your patients will respond to the combination arm. But do we have a huge difference? If you look at the median progression-free survival, you'll only find 5.6 versus 3.4. So you're paying lots of money to gain only progression-free survival of 2 months. So we need to think before using this combination. So we get the immune checkpoint inhibitors with the anti-VEGF versus the sorafenib, and here the sorafenib is acting as an anti-VEGF. So if you combine both, yes, you will find that the overall survival was in favor of the combination arm versus the sorafenib as single agent. And this clinical trial gave the approval to be category 1 for the combination arm to be the first line in hepatocellular carcinoma. What about the progression-free survival? If you concentrate here, you'll find that you only added 2 months. So what I'm just telling you here, that with using the immune checkpoint inhibitors, you need to cherry pick your patients, only specific patient, child A, and believe me, they don't work in B7 or whatever is said in the literature because we've tried it before, don't work. Okay, so you have to highly select your patients. The patient should have lots of money or sponsored to pay lots of money. What about the quality of life deterioration? Actually, with the combined arm, you get a better quality of life to your patients. Again, for the first plot, you'll see that the only not in favor is the BCLC stage B, which was in favor of sorafenib. Again, this shows you that the combination is not even the choice. We have to choose our patients. What about second line? We do have lots in combination. So patients with previously receiving sorafenib, what about if we gave them single agent immune checkpoint inhibitors? And if you can look here at the escalated or expansion, meaning that I give specific dose or increase the dose, you'll find no response. The two curves are identical. But if we look at the best overall response, the CR definitely would have the best response, but this was only phase 2 clinical trial. Phase 3, pembrolizumab in second line. Again, the overall survival is marginal, as you can see. And you can see from my enthusiasm that I'm not pressing on using immune checkpoint inhibitors, although I'm coming today to defend the immune checkpoint inhibitors. And I'm scared from my professor who will kill me with the questions later on. So if we look at the most updated NCCN guidelines, the National Comprehensive Cancer Network of the USA, you will find that atezolizumab, which is an anti-PD-L1, in combination with an anti-VEGF, is category 1, which is the highest category and level of evidence. While if you look here at other recommended regimens, you will find that sorafenib, lenvatinib, and only in child PO-A, as I showed you. So the B7, it's only present in sorafenib. You won't find it in the immune checkpoint inhibitors or the lenvatinib. And then if you go through, if there is no category written beside it, so it's only category 2A, you're allowed to use it or you don't want to use it. So to conclude, hepatocellular carcinoma is one of the most lethal malignancies proven by the paper which was published in Egypt. I'm sorry. So lung is still number 1, but in Egypt, it's still higher than the lung based on the paper by Professor Amal Sami Ibrahim published in 2014. So I'm talking about Egypt here. Don't get me wrong, please. Treatment options, again, is still limited, whether by toxicity, financially, or clinically. The microenvironment is immune rich. We need to tackle it. We need to find a way to tackle this rich environment, and not only by immune checkpoint inhibitors alone. Proper selection for immune checkpoint inhibitors for our patients, I need to cherry pick my patients. Not all patients are eligible for immune checkpoint inhibitors, and definitely we need more trials. And again, coming to Professor Muhammad, who spoke, the first lecturer who spoke, we need the MDT meeting. Hepatologists, oncologists, hepatosurgeons, even radiotherapists, and palliative care medicine. And thank you so much for listening. Questions, or should I escape?
Thank you so much, Dr. Muhammad Abdullah Bin, Dr. Ahmed Magdi. Again, I will ask about the fibrolamellar carcinoma. It's annoying me because it's occurring without any symptoms, can occur on a fatty liver, and it's lethal, occurring in young age. There is an Egyptian experience about that type of hepatocellular carcinoma on the fatty liver?
To my knowledge, no.
No, till now.
I've used sorafenib with fibrolamellar patients.
Yeah.
Basically, patients in child PO-A, and they're younger than 40 years old.
Yeah.
But I'm with Professor Muhammad Abdullah. I've never used sorafenib in elderly patient or more than child PO. I don't even use them in elderly patient, not even child PO-A.
Okay. Okay. Thank you.
Thank you.
Dr. Magdi, the immune therapy based on 2 lines. The first line is to enhance the already present immune system, or to invent new immune reactions. What about the oncolytic therapy?
Oncolytic?
Oncolytic therapy, the virus.
Okay, excellent question. So oncolytic viruses has been established in melanoma, but for hepatocellular carcinoma, it's not yet. Why oncolytic virus? Because oncolytic virus needs to be injected directly in the tumor. It needs to evade the immune system, because if we inject the oncolytic virus, it will be attacked by our immune system or the intact immune system outside. So it will kill the virus and it won't reach the hepatocellular carcinoma. So basically, it's the difficulty of doing it because it's a tiresome clinical procedures. It needs to be highly picked, and then it needs to be directly injected inside the tumor itself.
Okay.
But for the hepatocellular carcinoma, to my knowledge, and Professor Muhammad, we don't have any data till now. It's only in melanoma.
Also, I want to raise the issue of using the immunotherapy as a local regional, not a systemic, because there is a trend in the world now to combine the endovascular treatment and to tag this immunotherapy on the beads. You know that traditionally now we do the bead therapy, and to load the desoxyribonucleic on this and to use it for the chemoembolization. Now there is a trend, this is in the literature. I want to know if you have any idea about that we combine the beads and the cytotoxic drug with the immune therapy, as well as the injection of this into the tumor itself. And this might be a combination therapy that might prove something that might lined up in the future in the treatment of HCC. Do you agree on delivering this immunotherapy in low doses attached with the bead therapy into the tumor instead of giving large doses in systemic? Do you have anything in mind?
To tell you the truth, I don't have the data, but if you're asking my personal recommendation, I would not recommend giving both together. So if we're trying to put a theory here, if you do the injection with the beads, with the cytotoxic chemotherapy, this will induce inflammation in the tumor, hence getting more immune cells inside the tumor. Then I can use the
in a systemic way, yes. In a systemic way, yes.
Yes.
This is a traditional now, combined systemic immunotherapy with the chemoembolization or beads or even bland embolization. But what is in the new literature that we put the immunotherapy in the catheter itself and try to deliver it to the tumor?
I'm sorry, to my knowledge, I don't know, but Professor Muhammad.
Okay.
Excuse me, I want to go back to Professor Shuriba. In just 1 minute, I'd like to ask about surveillance in this group of patients who develop HCC in a non-cirrhotic liver. They have the advantage of normal liver reserve, but unfortunately, because they don't apply and we don't expect them to have HCC, so they don't undergo any surveillance program. So we know quite well that alpha-fetoprotein, even in cirrhotic patients, is not that much sensitive, and they need to apply other scoring systems such as GALAD. They apply PIVCA2, for example. So if you think of surveillance in this group of patients, who are the group of patients you would like to do surveillance from them? And what markers will you be using in order to apply surveillance?
All right, that's a great question, and I don't think anybody has an easy answer for it. I expect that as the volume of those non-cirrhotic NAFL patients, which we said currently about a third, according to the US data that develop HCC, as the volume of this population increases with the epidemic of HCC, we will have to come up with a consensus on how to surveillance those patients. I think the big challenge in them also is that if you utilize ultrasound, and we acknowledge the limitations of ultrasound in early detection of HCC, well, it's going to be more challenging in a bright steatotic liver. So the detection of the ultrasound is going to be really low. So we're talking about using an expensive dynamic modality, either a CT or an MRI. So I typically use in my cirrhotics that are obese with limited ultrasound findings and MRI. So would the future be an MRI and maybe elastography, MR elastography? We use that now to risk stratify those patients in terms of the presence of fibrosis. So a non-invasive method. So maybe in the future, it would be a combination of MR and MR elastography to kind of know which patient has a stiffer liver, if you will, a liver that has a lot of scar tissue, and you could enroll them in surveillance. So that's what I personally envision. I think the utilization of AFP has more of a diagnostic value, and we said it has lower sensitivity in a non-cirrhotic liver. And we typically rely on seeing a cirrhotic decompensating or looking jaundice to figure out that they might have a problem, and we have them in surveillance. But a non-cirrhotic liver, as you rightfully said, have a big reserve and may present really late with symptoms when it's already difficult to intervene or do something. So I envision MR with elastography as a future modality to do that. Thank you for the question, Dr. Shuri.
Thank you. Thank you for the answer.
It's Rahmat Hosni. Now he will speak. You are. Okay. Thank you, Dr. Hedi, for the perfect organization, title selection and subtitle selection, and perfect presentation. We are really all enjoyed. Thank you for this great job. Now you will give us cases of related combined local radiological therapy and immunotherapy in hepatocellular carcinoma. Dr. Hedi Ayman, lecturer of endemic medicine, Cairo University. The floor is yours.
Thank you so much, Professor Mona Higazi, for the lovely introduction. Thank you, Mr. Chairman. First of all, I would like to thank my dearest professor, Professor Siraj Zakaria, for his very kind invitation, and to thank all my dear professors, Professor Ahmed Sami, Professor Amr Abdelail, Professor Mona Higazi, Professor Zainab Ahmed, Professor Sharif Mugawar, and Professor Muhammad Mahmoud and Dr. Muhammad Bassam for their valuable presence. Dear professors and colleagues, my talk today will be about the emerging opportunities for combining local regional therapy with immune checkpoint inhibitors in hepatocellular carcinoma. As you all may know, the treatment options for hepatocellular carcinoma vary depending on the extent of the disease, ranging from local regional treatments for localized disease to systemic therapy for multifocal or metastatic hepatocellular carcinoma. Local regional therapies, including radiofrequency ablation, transarterial chemoembolization, and transarterial radioembolization, are recommended for patients who are not eligible for surgical resection or liver transplantation, yet most patients eventually develop refractory disease that requires the use of systemic therapy. As delineated earlier by my dear professors, Professor Dr. Muhammad Abdullah and Dr. Ahmed Magdi, the use of immunotherapy to treat cancer is now rapidly leading a new era of hepatocellular carcinoma treatment, despite their failure to demonstrate a strong response, where they only showed a modest activity in hepatocellular carcinoma as single agents, both in the first line and the post-sorafenib second line settings with unsatisfactory overall response rates. For this reason, finding ways to further enhance the comprehensive anti-tumor immune efficacy of immune checkpoint inhibitors has now become a major focus of hepatocellular carcinoma treatment, whether their combination with anti-angiogenesis agents, with anti-angiogenesis agents is now moving to the frontline setting based on promising efficacy data from studies such as the IMbrave study and the Himalaya and the Cosmic and the LEAP-1 study, as previously explained by Dr. Ahmed Magdi. Besides the combinations featuring immune checkpoint inhibitors with anti-VEGF agents or anti-angiogenesis agents, and the combinations featuring different immune checkpoint inhibitors together, the obvious question is whether there is a rationale to support the combination of immunotherapy and local regional therapies, given the established effect of each approach separately in hepatocellular carcinoma, and whether the modest effect of single agent immunotherapy in the advanced setting can be moved to the adjuvant setting post local regional therapies. The intrinsic immunosuppressant nature of the liver microenvironment, which is largely driven by the abundance of regulatory T cells, is majorly responsible and plays a major role in creating a barrier against anti-tumor activity. The basis of use of immune checkpoint inhibitors, as previously explained by my dear professors, is that immune checkpoint blockage removes the inhibitory signals of T cell activation, which enables tumor-reactive T cells to overcome regulatory mechanisms and mount an effective anti-tumor response. The efficacy of immune checkpoint inhibitors to do so depends on a number of factors, including the degree of expression of PD-L1, and the degree and the levels of circulating immune cells and intratumoral immune cells, and the degree of expression of neoantigens. The rationale for combining immune checkpoint inhibitors with local regional therapies among patients with hepatocellular carcinoma is therefore based on the favorable immune modulation effects of local regional therapies, which can promote the efficacy of immune checkpoint inhibitors through different mechanisms. Besides local tumor ablation and control, local regional therapies, including RFA, TACE, cryoablation, and TARE, can also modulate the tumor microenvironment through several interrelated but complex mechanisms. For instance, ablation leads to a process called immune cell death, which leads to the release of new antigens and to PD-L1 upregulation. In addition, they can also modulate the tumor microenvironment with enhanced antigen presentation and eventually T cell regulation or T cell upregulation. Various modalities for local ablation, including thermal ablation techniques such as radiofrequency ablation, microwave ablation, cryotherapy, and irreversible electroporation, collectively enhance the effects of immune checkpoint inhibitors through several mechanisms. And these mechanisms include the facilitation of the release of tumor-associated antigens, and this actually represents a major prerequisite for immune activation. Local ablation as well manages to change the level of cytokine expression, where it enhances the pro-inflammatory cytokines such as interferon gamma, tumor necrosis factor alpha, interleukin 1 and interleukin 2, with inhibition of the pro-inhibitory cytokines such as interleukin 10. Finally, they can also manage to promote the immune function of lymphocytes, where the increase in the levels of tumor-infiltrating lymphocytes and the circulating peripheral lymphocytes manages to eventually increase the activity of cytotoxic T lymphocytes. Similarly, a transarterial chemoembolization also has some immunomodulatory effects, where the local tumor necrosis that occurs following the occlusion of the feeding arteries leads to the release of tumor antigens, which are then captured by antigen-presenting cells and lead to the activation of tumor-specific immune responses. In addition, TACE can also change the cytokine spectrum in the tumor microenvironment, leading to enhanced pro-stimulatory cytokines such as interferon gamma, interleukin 1, and the suppression of pro-inhibitory cytokines such as interleukin 10 with increased expression of T helper 17 cells. Finally, in addition to that, in patients with low baseline regulatory T cells, TACE can transfer the tumor microenvironment into T helper 1 dominance and obtain a favorable survival prognosis. In a similar fashion, transarterial radioembolization can also show some immunomodulatory effects, where it leads to the priming of tumor-specific T cells and attraction of leukocytes into the tumor tissue, the regulation of tumor microenvironment, and an increase in the sensibility of the tumor cells to cytotoxicity induced by lymphocytes. Currently, we have a number of ongoing trials evaluating the efficacy of combination of local regional therapy with immune checkpoint inhibitors in hepatocellular carcinoma. In a recent systematic review using the keywords local regional therapy and immune checkpoint inhibitors in addition to clinicaltrials.gov, it succeeded to identify a number of 45 ongoing trials featuring combinations of different immune checkpoint inhibitors with local regional therapies in a number of solid tumors, and most of these trials were conducted on hepatocellular carcinoma. Now, looking at the ongoing trials evaluating such combinations in hepatocellular carcinoma, we can see that most ongoing trials are actually early phase 1 and 2 trials, and they are testing different modalities for local regional therapy, including TACE and radioembolization, radiofrequency ablation, and cryotherapy, versus, in addition to a number of immune checkpoint inhibitors, such as tremelimumab, nivolumab, and durvalumab. The most promising of those ongoing trials include the EMERALD-1 study, which is a phase 3 randomized trials in which approximately 600 patients are randomized in a 1-to-1-to-1 fashion to receive either durvalumab plus TACE followed by durvalumab alone, or durvalumab plus TACE followed by durvalumab and bevacizumab, or TACE alone. The primary endpoint for the study is the progression-free survival, and the expected secondary endpoints are safety, overall survival, and time to progression, overall response rates, and disease control rates. Another very interesting study is the DEMAND study, which is a currently ongoing phase 2 randomized trial testing the efficacy of the atezobev combination followed by on-demand selective TACE on detection of disease progression versus the use of initial synchronous treatment with TACE and atezobev together. Lastly, another phase 3 randomized trial that's currently ongoing is the LEAP-12 study, which is a randomized trial that randomizes approximately 950 patients into receiving either a combination of lenvatinib plus pembrolizumab in addition to TACE, or to receive TACE plus placebo. The co-primary endpoints of this trial include overall survival and progression-free survival, and the secondary endpoints include objective response rates, disease control rates, duration of response, and the time to progression and safety. Finally, my take-home message is that the combination of local regional therapies with immune checkpoint inhibitors represents a possible promising future option for patients with hepatocellular carcinoma, and that the outcomes of current, new and ongoing clinical trials have the potential to change the management of patients with advanced hepatocellular carcinoma. And now, Professor Ahmed Hosni, Professor of Interventional Radiology at Cairo University, will present to us some real-life data from successfully treated cases that were successfully treated using combinations of local regional therapies and immune checkpoint inhibitors.
Thank you, Dr. Hadi. First, I want to thank my dear Professor, Dr. Siraj Zakaria, for the kind invitation, and to thank the organizing committee for establishing this important, outstanding, updated session about one of the mostly commonly faced health problem we are facing nowadays. I created my presentation to be like a case presentation with discussion with the chairpersons and our professors in the floor to learn from them how to think about these complex HCC cases. HCC is the fifth most common neoplasm and the third most common cause of this. Portal vein thrombosis is present from 10 to 40% of cases at time of diagnosis. We are still working according to the BCLC classification system, as it incorporates not only factors related to the neoplasm like the number, the size, and the vascular invasion, but also it incorporates the general condition of the patient in the form of the echo performance, and the liver condition of the patient in the form of the Child-Pugh score. Our target population in this study, in this presentation, is the intermediate and advanced stage of HCC. The intermediate stage is diagnosed as or defined as presence of single large or multifocal HCC. The patient is asymptomatic, there is no vascular invasion, no extrahepatic spread, with preserved liver function being Child-Pugh class A and or B. The survival of those patients, if left untreated, is 1.5 years. The recommended treatment according to the BCLC is chemoembolization. While stage C or advanced HCC is diagnosed by presence of symptomatic patient with echo performance 1 or 2, presence of macrovascular invasion plus or minus extrahepatic spread. Survival of those patients, if left untreated, is 6 months, and the treatment option according to the BCLC is the sorafenib and the new TKIs and immunotherapy like Dr. Muhammad and Dr. Ahmed Magdi said. But we all agreed that the sorafenib has only short increased survival time for 3 months according to the SHARP trial published in 2008, and it has many side effects. So we rarely describe it to the patients. The overall prognosis of untreated HCC 5-year survival rate is less than 5% if left untreated. So going to the first case, the patient is male patient presented to us in November 2018. He's 64 years old, accidental discovery of large HCC, his Child-Pugh class A6, echo performance 1, bilirubin 1.3, alpha-FeTO 1070. He has multicenteric HCC. The first mass is well-capsulated, highly vascular mass in segment 4A of the left hepatic lobe. Then he has large infiltrative lesion in the posterior segment of the right hepatic lobe here. It occupies segment 6 and segment 7. The lesion invades the right hepatic vein and almost completely occludes the IVC. Only a thin rim of enhancement is seen in the IVC, while the rest of the IVT is completely occluded. The lesion is also invading the posterior division of the right portal vein, as we can see here. And it reached to occlude the whole right portal vein. This is the right portal vein, it's totally occluded, and the left portal vein is patent. This is a very important image that we called MR diffusion. It will show the tumor load inside the liver. We will use this image in the next follow-ups. Here you can see the tumor load inside the right hepatic lobe, as well as presence of 2 satellites in the left hepatic lobe also. According to the BCLC, we are in the advanced stage, or BCLC class C. So now I want to discuss with our hepatologists, Dr. Mona, Dr. Zainab, Dr. Bassam, and in the Zoom, Dr. Sharif Magawar, and I do think Dr. Muhammad Mahmoud is present with us. So how can we think about this case, or how we can navigate in this case?
طبعا حجم التيومر هنا كبير والعين تشايلد سي تشايلد ايه
A6
سي هو السورافيناب هيبقى هو الاوبشن بتاعه لان ده ادفانسد تيومر.
تمام. هو according للبي سي ال سي هو السورافيناب هو الاونلي انديكيتد اوبشن. تمام. بس احنا عارفين ان السورافيناب اونلي بينكريز السرفايفل 3 شهور. السورافيناب الايم بتاعه stabilization of the disease, it not reach the disease itself, but try to stabilize, and it succeed in 20% and fail in 80%. So we don't like to prescribe it much.
دكتور احمد بعد اذنك، هو ده طبعا ادفانس ستيج سي وفيها البورتال انفيجن، والبرفورمانس ستيج بتاعه يعني 1 to 2، فاحنا we can apply systemic therapy whether الكاينيز inhibitor or immune checkpoint inhibitors. يعني اعتقد ان احنا في خانه السيستميك ثيرابي، والتشويس ما بين الاثنين بقى هيبقى هو اللي احنا لازم نكونكلود whether this or this. السورافينايب زي ما احنا سمعنا الريزلتس بتاعته ما هياش promising، فيمكن العيان ده يكون الاميون تشيك بوينت يمكن يكون مناسب كسelection.
If I may ask.
Sure. Yeah.
Does the patient have a lot of shunts on the imaging? Is there a lot of shunting there?
Yes.
I didn't see much going on.
This is a very important point. We will discuss it later. Okay. I'll show it in the angio.
I think Dr. Muhammad Mahmoud معاك.
Dr. Muhammad Mahmoud, okay, go on.
I think this patient may benefit from radioembolization plus systemic therapy.
Okay, and this is our topic today. Dr. Muhammad Abdullah and Dr. Ahmed Magdi, from the oncological point of view, showed us the immunotherapy only showed poor response to HCC. But we are now talking about a new era, is the combination of local regional therapies and the immunotherapy. So from the surgical point of view, Dr. Amr, do you have any comment? It's okay. Okay, we discussed with the patient and we choose to treat him with combined intra-arterial therapies and immunotherapy. What was our rationale? Our rationale was that chemoembolization radiofrequency tear, as Dr. Hedi told us, is expected to enhance the effect of immunotherapy by inducing local inflammation. This would lead to release of the new antigens that activate the antigen presentation and the relevant immune system activation. This article retrospectively analyzed the immunogenic effect of intra-arterial local regional therapies in hepatocellular carcinoma in a rationale for combining selective internal radiation therapy or SIRT and immunotherapy, and they concluded that SIRT significantly promote recruitment and activation of intratumor effector type immune cells compared to TACE, or no preoperative treatment. This result suggests that SIRT is a better candidate than TACE to be combined with immunotherapy in treatment of HCC. TACEs can be performed by one of the three ways, either by blend embolization using particles, or by chemoembolization mixing libidol and doxorubicin, or by drug-eluting beads using doxorubicin-eluted drug-eluting beads, and of course, yttrium-90 or radioembolization. To know the difference between the chemoembolization and the radioembolization, we have to discuss two important points. First, the particle size, and second, the type of tumor kill. For the particle size, in the right side of the screen, you can see the particle size of the chemoembolization particles. The conventional libidol particle is 5 to 900 microns, while the drug-eluting beads and the blend embolization is 1 to 500 in diameter, while the arteriolar diameter is from 20 to 40 and the tumor end arteriole is 8 micron. This means the chemoembolization particle will not enter the tumor bed itself. It will occlude the arteriolar liver outside the tumor, leading to ischemia of the tumor and the release of chemotherapy inside the tumor. While the radioembolization particle is 20 micron in diameter, so it can penetrate the tumor itself and embed itself inside the tumor and delivering its substance inside the tumor itself, as in the next diagram. Here is the chemoembolization particle occluding the arteriole outside the tumor itself, leading to ischemia of the tumor, and the tumor kill will be mainly by ischemia. While the radioembolization particle is very small enough to have an access to inside the tumor, each of these particles emit radiation for 1 centimeter around its substance. So the tumor kill will be mainly by radiation and not by ischemia. Radioembolization is performed in 2 sessions. The first session is the standard session, where we address all the hepatic tumors and address the hepatic supplier to these tumors. Then we inject the macroaggregated albumin and do SPECT scan for the whole body, aiming to get 3 points. The first point, the tumor load of the macroaggregated albumin, and this should be high. So the yttrium 90 will go to the tumor itself. The second part, or I like to call it the safety procedure, as we make sure that the intestine having 0% of macroaggregated albumin reaching it, and the lung reaching less than 20%. If the patient bypass the standard session, it is a safe procedure for him. These are the images we get from the first session. As you can see here, the macroaggregated albumin is concentrated mostly inside the tumor, so we know this patient will get benefit from radioembolization. The treatment session is performed 1 week after the standard session with delivery of the yttrium 90 itself. Back to our case and our dear professor, Dr. Ahmed Sami. Dear professor, we have multicenteric HCC infiltrative in nature, invasion of the hepatic vein and IVC, as well as invasion of the portal vein. How do you like to treat this patient, by chemoembolization or radioembolization, considering we have hepatic venous invasion?
Of course, radioembolization would be the first line of treatment because of the microvascular invasion. This is the standard treatment for this patient according to the images you showed to us, considering that the chemicals or the serological stress of the patients are fitting with treating the patient with this kind of treatment. Second, we're going to talk now about the combination with the check protein inhibitors, and this is with add, according to the literature we have available now, that if you add this kind of treatment systemically, this would add benefit to the patient. In spite of the results, I mean, according to the literature, are not very significantly high, but this is the way to approach this kind of treatment. Especially, there's a trend now that to put also the check protein inhibitors into the endovascular treatment to decrease dose, same time decrease the expenses, and at the same time to have it targeted into the tumor cell.
Thank you, Dr. Ahmed. As Dr. Ahmed said, and as the article showed us, like before, CERT is more immunogenic than chemoembolization. But in this particular case, we have invasion of the hepatic vein and the IVC, and this in our throat will lead to increased amount of yttrium reaching the lungs, and the lung shunt will be more than 20%. If more than 20% of the yttrium reaches the lung, it will induce radiation-induced pneumonitis, and it is fatal procedure. So we discussed with the patient and the oncologist, and despite the patient came actually for radioembolization, but we shifted him for chemoembolization. We enter super selectively in the first mass, which is the capsulated mass, and injected particles, terminal particles. Then as Dr. Muhammad from USA told us from the imaging, and I want to thank you, and I want to thank him, there is significant shunt from the infiltrative mass into this is the IVC, and this is the hepatic vein. So this is the infiltrative lesion itself. You can see here infiltration of the posterior segment of the right lobe, invasion of the hepatic vein and the IVC, and this is the portal vein invasion. After the procedure, by 3 weeks, the patient received immune check inhibitors, which is nivolumab, for 3 months, and after 5 months, he performed a new CT. Here are the arterial phases. You can see mild enhancement of the lesion, which is much reduced from the pre-procedural images. In the portal phase, you can see here atrophy of the right hepatic lobe and hypertrophy of the left hepatic lobe. The thrombosis inside the IVC is much retracted, and around 50% of the diameter of the IVC is patent now. The portal vein, the right portal vein, which was totally occluded, now see is also retracted inside the right portal vein, and there is now enhancement inside the right portal vein. The patient received another 3 sessions of immunotherapy, and sorry, this is the MR diffusion after the first follow-up, as compared to the MR diffusion before treatment. As you can see here, there is marked reduction in the tumor load inside the liver. The patient is still child A, alpha-fetoprotein was dropped, so he received another 3 months of immunotherapy. Then 13 months after the presentation, he performed another MRI. As you can see here, there is absence of any enhancements. There is complete atrophy of the right hepatic lobe and the hypertrophy of the left hepatic lobe. The IVC is almost patent now, only small thrombus is adherent to the wall. The right portal vein, as you can see here, showed more and more patency and blood inside it. And this is the new MR diffusion after 13 months of the procedure, showing no enhancement of the lesion as compared to the pre. These are the pre-images, and these are the images 13 months after the procedure. The patient is survived 23 months, and he is still surviving until now. Any comment from the chairperson? Okay, I'll go to the second case. The second case is presented to us in June 2017. He is a male patient, 71 years old. He received direct antiviral treatment 1 year ago and discovered the hepatic mass in routine follow-up. The patient is a child A5, AKIT performance 0, total bilirubin 0.6, albumin 3.5, INR1, and alpha-fetoprotein was 3,600. He had aggressive infiltrative mass in the right hepatic lobe, segment 7, which is 8 centimeters in diameter. This is in the coronal image. The portal face showing the infiltrative nature of the lesion, as we can see here, and there is invasion and the total occlusion of the right portal vein itself. And as the patient has extra hepatic spread in the form of a large 5 centimeter right paracaval lymph node. This is the resume of the patient. So we discussed with the patient and with his oncologist. And I wanted Dr. Muhammad to present here, but he had to go, unfortunately. So we treated him, like Dr. Ahmed Sami said, was radioembolization and immunotherapy, nivolumab. The patient was lucky enough, he received all his blood supply from 3 subsegmental arteries. We enter through these 3 arteries and we inject the yttrium to deliver all the yttrium inside the tumor and protect the rest of the liver tissue from any hazardous events. 7 months after the procedure, then he received the nivolumab. 7 months after the procedure, you can see here in the arterial and portal phase, complete necrosis of the lesion with absence of any enhancement, and in the portal phase there is necrosis of the lesion. The portal vein is still occluded, yet it is attenuated, and there is no enhancement inside, denoting necrosis of the intravascular component of the lesion. The para-aortic, the paracaval lymph node showed mild decrease in size. It is now around 3 centimeters in size. This was 7 months after the treatment plan. The patient's child A and alpha-fetoprotein was dropped to 250. 14 months after the patient follow up with his oncologist. 14 months after the presentation, he performed a PET scan that showed no evidence of active metabolically hepatic focal lesions, yet there is activation of the right paracaval lymph node, measuring now 5 centimeters again. The patient survived and died after 34 months of the procedure. Actually, in those lesions with extrahepatic spread, we do not expect survival more than 3 months. So to live for 34 months is a great benefit for him. The case 3 is a male patient, 64 years old, hepatitis C. He complains of abdominal pains and mild loss of weight. By imaging, he has infiltrative mass in the right hepatic lobe, portal vein invasion in the right side, and bilateral large suprarenal mass. He discussed with his oncologist and he started his immune therapy before any local therapy. After he received the 3 months of nivolumab and performed the follow-up, he had progression of the hepatic and the suprarenal masses and marked elevation of the alpha-fetoprotein. The patient is presented to us now by child A. 5, bilirubin 0.9, albumin 3.1, alpha-fetoprotein 2,700, and echo performance 0. He is a liver surgeon. He is a very active surgeon doing his procedures and going to his clinic. And this all was by accidental discovery. In the arterial phase here, you can see an infiltrative mass in the right hepatic lobe invading the whole right portal vein, which is totally occluded like here in the venous phase. You can see the portal invasion better in the coronal images, where you can see distension in the right portal vein. The thrombus is seen approaching here in the left portal vein and approaching the main portal vein itself. This is a large left suprarenal mass around 12 centimeters in diameter, like you can see here. And this was progressed on immunotherapy, like Dr. Muhammad Abdullah said. In the PET scan here, you can see the marked activity of the intrahepatic component of the lesion and the suprarenal mass, which is 12 centimeters in diameter. So we discussed with him and his oncologist and chose to treat him with intra-arterial radioembolization and immunotherapy again. Now, after 3 months of the procedure, these are the pre-images and these are the post-images. You can see complete necrosis of the hepatic focal lesion itself. It is completely transformed into necrotic tissue. The portal vein extension inside the right portal vein showed mild regression, and there is more necrosis inside the portal vein malignant thrombus itself. We will see it in the coronal images better. In the axial venous images, you can see regression of the portal vein thrombus as regards the extension of the portal vein itself and the degree of enhancement. In the same session of radioembolization, we enter super selectively inside the suprarenal mass and we inject blunt particles. Here you can see in the new images more necrosis of the suprarenal mass. We know that we do not hope for cure for this patient. We are just doing evaluation and increasing survival of this end-stage lesion. In the coronal images here, you can see well the portal vein thrombosis before the procedure and the retraction of the thrombus inside the right portal vein. This is the old image showing the thrombus approaching the main and the left portal vein. Now the confluence of the portal vein is completely patent. The PET scan performed showed necrosis of the lesion itself. As you can see here, there is absence of any SUV activity. And also decrease in the SUV activity of the suprarenal mass. The patient is still child A, echo performance well, he is doing his work well, and he started to receive another sessions of immunotherapy. Last week, this images was last week. So my take-home message is that multidisciplinary approach is very crucial in treating patients with HCC between the hepatologist, oncologist, liver surgeons, and interventional radiologists. Local regional therapies combined with immunotherapy carry a great hope in treating advanced HCC cases, yet it still needs further prospective studies. Thank you.
دكتور احمد، عايز اسالك سؤال. يعني طبعا بشكرك جدا على المحاضره الجيده جدا. سؤالي في العيانين اللي عندهم extensive shunting و you decided انك تعمل radio embolization, how do you manage the shunts? Do you do coiling for example? وايه الديجري اللي بعدها تقول لا ده ما يتعملوش radio embolization لان الشانس اكتر من اللازم ما اقدرش اعمل لها coiling؟ فممكن تديني افاده عن هذا السؤال؟
Thank you, Dr. Sharif. Actually, if we expect shunting by imaging, like Dr. Muhammad from USA suspected, and like in our first case, we don't like to do tear procedure. Do we have a technical point that we can perform to do the shunting? Yes, we can inject particles inside the shunt itself to occlude it. Then we inject macro-aggregated albumin and send the patient to get the PET scan, the SPECT images. In the SPECT images, they will tell us the degree of lung shunting. If it is less than 20% lung shunting, so we succeeded to reduce the shunt to a suitable limit. If it is not, we have not to perform radioembolization and we shift to another type of treatment.
دكتور احمد.
Thank you.
دكتور احمد، احب اشكرك على البرزنتيشن الجميله دي والحالات الجميله دي كالعاده يعني. بس انا بسال برضه احنا ليه حالات كتير من الحالات اللي انت عرضتها ما كانش في بيت سكان قبل البروسيجر يعني، او هل ده كده هتفرق معاك يعني في الديسيجن ولا لا؟
This is a good question. We are not performing this combined way of therapy without PET scan. In all these patients, we have to perform PET scan to know if there is any extrahepatic spread. then we discuss the therapeutic option with the patient.
Thank you, Dr. Ahmed, for the illustrative, highly scientific presentation.